Hi, I'm Eric McGriff. I'm a PTA. Been a therapist since 2001, and I have about 12 years of therapy management experience. I'm going to talk to you a little bit today about billing, about Medicare, about different problems you may come into in clinical practice. I specialize in skilled nursing facilities. It's been where the focus of my therapy has been, but a lot of the information passes from setting to setting. So, Medicare policies sometimes for skilled patients may vary from setting to setting, but the policies for Part B patients do not. I'm actually getting a little ahead of myself because we're going to go through all that, but just wanted to give you a background that my focus is skilled nursing facilities, and this information definitely pertains to skilled nursing facilities, but it also will pertain to you if you go into a different type of clinical setting. So I'm just going to jump into it, keep you guys nice, short, and sweet. So first thing we want to talk about is Medicare itself. Medicare patients that you're going to deal with are going to fall into two different categories. You're going to have a category of Medicare patient called Medicare Part A, and you're also going to have another category called Medicare Part B. For your Medicare Part A patients, those are what you will hear referred to as skilled residents. So if you're in a skilled nursing facility and they say, oh, we have another skilled resident, that's somebody that's coming in under the Medicare Part A program. The stipulations for that program currently, and it changes annually, sometimes even quarterly, but currently you have to have a 3-day stay in the hospital to qualify to go to a skilled nursing facility as a skilled patient. So once the patient stays in the hospital as an inpatient for 3 days, they can then admit to a skilled nursing facility as a skilled resident. And the reimbursement for that patient is then based off of the amount of treatment minutes that are provided to them. The other type of Medicare Part B, those are patients that are typically have been in the facility for a while. They haven't had a qualifying hospital stay to where they can get to Part A, but they've been in the facility and we've looked at them and decided, you know what, we can help them. We're going to pick them up, and Medicare Part B is going to pay for our therapy. Medicare Part B is also considered outpatient therapy, and we can bill it as outpatient therapy in skilled nursing even without an outpatient department, just because that's how the rules and regulations are set up. So for Medicare Part B patients, what you have to look at is it's based off of CPT coding. We'll go over a little bit of that when we meet live and have a chat. But in the meantime, you guys should probably look up and see what you can find on CPT coding and criteria, especially as it pertains to you guys as speech therapists. What you're going to find is CPT coding falls under two different categories. Category number one are what they call service-based CPT codes. And category number two are what are called time-based CPT codes. The service-based CPT codes are billed strictly as a service provided. So if it takes you 90 minutes to perform the service, you're going to get paid the same for that service as if it took you 30 minutes to perform that service. Now, the service-based codes reimbursement amounts are typically based off of how much they expect that those codes are going to cost for the facility or the therapist to provide those services. And then for your time-based CPT codes, the CPT codes are billed in minutes, or billed in units based off of minutes. And they use what they call an 8-minute rule to determine what those minutes are going to be. So, a 1 unit CPT code for time-based is considered 15 minutes. So if you provide from 15 minutes up to 22 minutes, you bill for one code. Now, if you have codes more time than that, it then goes off of that 8-minute rule. So from 23 minutes up to 37 minutes, that bills as 2 codes. Now from 38 minutes up to 38 minutes up to 52 minutes bills as 3 codes, and from 53 minutes up to 67 minutes bills as 4 codes. So you can kind of see that pattern just keeps repeating. But it is important that you know those. Speech therapy, the majority of your codes are going to fall into the service-based category, not the time-based category. But as you're doing your own research and looking up CPT codes for speech therapists, just take note of how they say they're billed, and then we'll discuss those when it comes time for our live meeting. So that kind of gives you a basic rundown of Part B services. Now, if we go back to Part A, that's really where, for nursing facilities, the bread and butter of their reimbursement comes in. And because our reimbursement is based off of minutes provided, they're also the facilities taking on with that service with that resident the entire amount of that resident's care, whether it be their medications are included, their food's included, room and board's included, all the nursing care is included, all the supplies that they need are included, all in that reimbursement rate. And the bulk of that rate is driven by therapy. So basically what you have in those reimbursement rates is you have what we call RUG categories. And RUG categories are broken up. The top category is called a Rehab Ultra High, or you'll hear people abbreviate it as an RU. Second category is a Rehab Very High, or an RV. Then you have a Rehab High, RH, a Rehab Medium, RM, or a Rehab Low, and RL. Rehab Low should very seldom ever seen used in nursing facilities because it also incorporates a lot of additional care that's required from what we call restorative nursing aid. But the other categories, the RM all the way up to the RU, those are what therapy lives in. So to break it down, for an RU, for a Rehab Ultra High classification, over the course of the 7-day period that they're looking at, the resident has to have a combined total of 720 minutes of therapy between all disciplines, broken up at least across 5 days of treatment. There has to be one discipline that does 5 days of treatment and at least one discipline that does 3 days of treatment to qualify for the Rehab Ultra High. Now, for the Rehab Very High, that is 500 minutes of therapy broken up across 5 days through all disciplines. And it only requires really one discipline to provide 5 days a week of therapy. It can be, like with Ultra High, it can be 7 days a week if that's what the facility's providing, but it's a minimum of 5. When we get down to a Rehab High, that starts breaking down. It requires one discipline, 5 days a week. It's only 325 minutes across those 5 days. Rehab Medium is 150 minutes, and it requires, it doesn't require a single discipline. It just requires that therapy has been provided on at least 5 different days. So you can have one therapy doing 3 days a week, another therapy doing 3 days a week, and as long as there are 5 different days that therapy is provided, they can still qualify for the Rehab Medium. So I won't go into Rehab Low because it's so very seldom used, and it shouldn't really affect what you're doing clinically. But I believe it's important to know what the different RUG categories are, just so that you understand when you get into a clinical setting why your department manager may be asking for a certain amount of minutes. A lot of times, I can do 60 minutes with them. Well, that may be fine and good, but if you do 60, if OT does 60 and speech does 60, 60 minutes a day. We've got 120 minutes a day. So we're really in between reimbursement categories, and if that's what it deems is appropriate, then, we're going to go ahead and run with that. But we certainly like to not go really far above or below any RUG category. We try and find what the patient's going to be most appropriate for and sit them into a RUG category that's appropriate for them. Biggest thing I think people need to understand, especially dealing with Medicare Part A, the first 20 days of Medicare are paid at 100%. After those 20 days, the resident starts into what are considered co-pay days. Now, those co-pay days have just a flat rate, and I believe right now it's $145 a day is what the people pay to be in the nursing home as a skilled resident past their 20th day. The reason that's important is because a lot of places you'll hear people say, oh, there's a 20% copay after 20 days. And that's not the case. It is a flat fee. It doesn't matter what RUG category they're in, they're paying the same amount. So typically what I look at as a manager is I want the residents to get the most bang for their buck. I always look at it and say, if it was my grandparent, if it was my mom and dad, what would I want them to get? I want them to get the most that they can out of that treatment time. It may not be that they can tolerate an ultra high. It may not be that they can tolerate a very high level of treatment. But what we have to look at is making sure that we're giving them as much as they can possibly tolerate, because they're paying the same. The cost isn't going to change. If we're providing 500 minutes a week, if we're providing 720 minutes a week, if we're providing 150 minutes a week, what they pay to be in that facility is going to be the same. So I always try and get them the most possible. If they can tolerate the 720 minutes a week, then by all means, I'm going to put them in at 720 minutes a week. If they can't, then we need to start backing down. But I always tell my therapist too to let me know as soon as you see that they can tolerate more, so that we can get them on board and we can really get them to that level. The more therapy they're going to get, the better they're going to get faster. So there's instances that we have to back it down, move it up, and things like that, and that's fine. But just understand, if you start hearing, well, there's a 20% copay, it's not 20%. It is a flat rate. Now, the reimbursement rates that the facility gets range dramatically. For an ultra high resident that's getting the maximum amount of care from nursing and things like that can bring in over $700 per day. And then it goes down to, there's different categories I won't bog you down with because it doesn't matter in what you're doing, but it can drop down into the low $400 a day. Very highs come in, real low 500s to the 300s, and, they fluctuate, but, that's where the money comes in. If we can get somebody at an ultra high that's a good resident that can tolerate that amount of therapy, and we're getting $600 a day for their treatment, we're profitable as a rehab department. The facility's profitable as long as they're sensible with the patients that they take. So it really does come in and be a really big factor in what you do as a therapist. There's a treatment side that we all know and love, but you have to remember that treatment is important. We have to give the therapist we have to give the patients what they need. But you also have to remember that this is a business. And sometimes that business side is going to push you to do things. It's going to ask you to be a different type of therapist. Maybe we're going to ask you to think more outside the box. You go through school, you see all these fancy equipment and things like that, and your facility might not afford them, but the patients still need that care. So that's a brief overview of Medicare Part A and of Medicare Part B. I'm going to take a break here in just a second, but I wanted to go over real quick. The only other thing you're going to run into as a payer is insurances outside of Medicare. So you can sometimes hear people referred to as a skilled patient that is not a Medicare patient, but they're an insurance patient. And typically what has happened is that resident has opted to not stick with a traditional Medicare plan, and they have gone with a secondary plan that acts as their Medicare beneficiary or their Medicare provider. So you see them on TV a lot. You got, Humana is a big one. Blue Cross Blue Shield does them as well. So they actually take over. You opt to go with that company instead of Medicare. So you still have similar Medicare benefits, but it will vary. They'll have coverage for SNFs, but sometimes the way that we get reimbursed through that company will vary depending on exactly what the parameters are. So when you run into those, your rehab manager in the facility should be able to explain to you what they need and how that patient needs to be treated differently. Sometimes we'll have providers that mandate 7-day-a-week treatment. And we just have to go with it. That's their requirement, and the facility, by taking the patient, has respected that requirement and agreed to provide it. So you might run into those instances too. So before we meet live, please take some time to review CPT coding as it pertains. You don't need to look at what OT and PT and all them have to deal with. Just pay attention specifically to speech therapy CPT codes. So I'm going to go ahead and take a break, and I will be back in a few minutes.